Good morning, everybody from India. Today, our guest speaker is Dr. Maria Capellini from Italy. She'll be speaking to us on problems in thalassemia beyond the age of 30 years. This webinar is brought to you by Mumbai Hematology Group. It is supported by Sun Pharma and it is managed by Perfect Square. I thank Mr. Arvind Suri and team from Sun Pharma and Sun Oncology, Mr. Yash Kalpesh and team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Gopinathan from Chennai, our guest speaker, Dr. Maria Capellini from Italy, all our discussants who are themselves eminent clinical hematologists, including pediatric hematologists, and you participants for sparing your Sunday morning, if you are from India, and Sunday afternoon or evening from the rest of the world. Next weekend, Saturday, at 7 p.m. IST and the US Central Time 8:30 a.m., we have a talk from Dr. Mark Lizzo on adult ALL, how to treat in 2025. And next Sunday, that is 13th April at 11:30 a.m. IST, the Melbourne time 4 p.m., we have Dr. Ashish Bajel speaking to us on future of allogenic transplants in acute myeloblastic leukemia. Our discussants today include Dr. Amit Khurana from Surat, Dr. Aditya Jandial from Chandigarh, Dr. Alka Khandwal from Chandigarh, Dr. Amita Mahajan from Delhi, Dr. Ankur Ahuja from Pune, Dr. Archit from Noida, Dr. Babita Sodhi from Delhi, Dr. Harshit Khurana from Delhi, Dr. Kunal Goyal from Mumbai, Dr. Manasa from Guwahati, Dr. Mehak Trehan from Delhi, Dr. Nailesh Shah from Ahmedabad, Dr. Nakul Tikare from Delhi, Dr. Neeta from Noida, Dr. Nitin Gupta from Delhi, Dr. Pradeep Reddy from Chandigarh, Dr. Rajat Bhattacharya from Kolkata, Dr. Shilpa Gupta from Mumbai, Dr. Shruti Kakkar from Ludhiana, Dr. Shubham Goswami from Delhi, and Dr. Sushma Baishya from Bangalore. Dr. Maria Capellini does not require any introduction to anybody who has to do anything with thalassemia. She has been our speaker in various webinars during last 5 years. She was also personally present in Mumbai for the meeting on thalassemia for the whole day. She is a professor of internal medicine at University of Milano, Italy, Department of Clinical Sciences and Community Health for last 25 years. Since 1999, that is for last 26 years, she is the chief of Thalassemia and Hemoglobinopathy Center at Milano. She is scientific advisor for the TIF and contributor to their meetings. She was instrumental in establishing the guidelines for the treatment of thalassemia published by TIF. She's done extensive research in the field of hereditary disorders of red cells, especially thalassemia. She has been an invited speaker and chair for various prestigious meetings around the world and various events across the globe. She was president of European Federation of Internal Medicine. Today, she'll speak to us on problems of thalassemia beyond the age of 30 years. Before she does this, we have our special guest, Dr. Gopinathan from Chennai, to inaugurate this webinar. Dr. Gopinathan is well known to all of you. He's consultant hematologist and BMT physician at MGM Healthcare, Chennai. He did his MBBS from the government Chengalpattu Medical College, Tamil Nadu, followed by MD in pediatrics from JIPMA, Puducherry. Then he was senior resident in pediatric and medical oncology at JIPMA. He did his DM in clinical hematology from SGPGI Lucknow. As a research project, he standardized LCMS technique for monitoring the therapeutic levels of methotrexate during high-dose methotrexate infusion in childhood acute lymphoblastic leukemia. His clinical interests include bone marrow failure syndromes, thalassemia, HLH, acute leukemia, bone marrow transplant, and cellular therapies. He has publications in the field of infantile cholestasis, HLH, AML induction toxicities, and GI manifestations of hematolymphoid malignancies. He was a gold medalist at the undergraduation and secured first rank in the DM hematology exam. He's developed bone marrow transplant services at MGM Healthcare and Cancer Institute, Chennai. I request Dr. Gopinathan to inaugurate our webinar and give us some words of wisdom.
Good morning, senior faculties, my dear colleagues and fellow juniors. At the outset, I would like to thank Professor Agarwal and the executive members of Mumbai Hematology Group for giving this opportunity and a platform to interact with all of you. Though it's too much of a privilege for me to be the special guest for today's event, but I would like to open my welcome note as an ardent fan and a well-wisher of Mumbai Hematology Group. To be more frank, I would say I would be a devotee of Mumbai Hematology Group. And thanks, sir, for organizing this webinar so organizedly every week so that it provides a lot of insights to the junior faculties. And I think all my senior faculties and colleagues over here would agree that this department, this particular subspecialty of medicine had grown leaps and bounds over the last decade, that in which what we learned as chapters in UG textbooks became individual textbooks in itself, and now they have become journals in itself. So, and I think with one side where malignant hematology is advancing with a lot of new classifications, drugs, and therapeutic advances, benign hematology is equally keeping in pace with newer diagnostic techniques as well as with the drugs. So, when we are talking about the today's topic, which is problems in thalassemia over 30 years, so that means we can see this topic in two perspectives. At one point, we can see that we are such a chronic disease which has its onset to childhood and continues to the adulthood. So only with improvised healthcare and a stringent follow, this is possible. And the second perspective to look at it is, as a young consultant and fellow juniors, that we need to keep, there is a lot more work that needs to be done in the preventive domain of the disease, so that we keep the global burden of the disease much, much lesser. And the third most important thing is we are very excited to learn from Professor Capellini today about the newer perspectives in thalassemia and particularly its contribution, particularly how to be managed in the adulthood. Like we have a lot of domains to be concentrated based on the multi-system involvement of thalassemia. So, and I'm very much excited to open this webinar for today's morning and hope to keep learning from all of you. Thank you.
Thank you, Gopinathan, for those lovely words and for inaugurating this webinar. Dr. Gopinathan, from the beginning of pandemic, I realized his potential and I saw him how regularly he attended these webinars, participated in the QA sessions, and then, of course, he got his DM through with flying colors, standing first in the university. So, Dr. Gopinathan, thank you very much for being with us today. And what can I say about Dr. Capellini? She has been someone whom I have been following to learn anything about thalassemia. As a postgraduate student, I did my thesis on thalassemia in 1976. And since then, my interest in thalassemia developed. Dr. Bernadette Model had visited India at that time as a WHO consultant. And I spent some time with her. Dr. Wonke has been a regular visitor to India those days to take care of the children of thalassemia those days, because we had only children. We didn't have adults in thalassemia. Now we have these adults, and how to care for them, Dr. Capellini is going to tell us today. So over to you, ma'am. You are muted, Dr. Capellini. No, you are still muted, Dr. Capellini.
Can you hear me now?
Now we can hear you. Yeah.
And can you see the slide?
We can see your slide very well.
Okay, so first of all, I would like to thank you, Dr. Agarwal, and the other colleague for this kind of introduction. I'm going to talk on problems in thalassemia behind the age of 30 years. These are my disclosure, and just to keep you on the subject of our presentation, I want to show you that the life expectancy of thalassemia patient is increasing all over the world. As you can see in this graph related to several surveys in different parts of the world. And just to moving forward, I can show you that the advances in management of patients with thalassemia have improved survival decade by decade, and over 2000 we have now several patients age more than 40 years. As you can see here in these survival curves from Italian cohort of patients, but it's similar in Greece or in other parts of the world. And more recently, in 2025, a paper has been published in Hematologica related to the prevalence and mortality trends of hemoglobinopathy in Italy. And the data are summarized in this paper that I suggest to look at because we have in this Italian cohort a follow-up over 50 years, and you can confirm that now we have cohort of patients age over 50. But what is also interesting is to see that the complication-free survival is increased, and the different complication we were used to see in our young or young adult thalassemia patients now is definitely changing. So why these changes were observed? But looking back to the 60s, at that time, the main focus was to correct the anemia, and we achieved that by transfusion. But of course, for several decades, we were looking at death due to primary cause of iron overload. So as you can see in the 80 till 2020 actually, the main cause was organ toxicity due to iron overload. Of course, the introduction of adequate iron chelation, either by desferrioxamine back to the 1980, but later on with the oral iron chelation, but particularly around 2000, the introduction of T2 star for measuring the iron load in the heart improve significantly the control of iron toxicity, having the possibility to adequate the iron chelation to the level of iron load in the heart. So all these things together, just to summarize the first part, were the reasons changing the survival. So introduction of regular transfusion, then introduction of proper iron chelation. I didn't mention the introduction of bone marrow transplantation that was initiated in 1984, but that's definitely also improve the, let's say, scenario of thalassemia, but it was limited to a subset of patients. But for the general thalassemia population, the changes were due to the iron chelation and novel iron chelator, T2 star introduction, and also it is not to be underestimated the multidisciplinary approach of the disease. So with this in mind, let's see what other challenges we are now facing with the advanced age in thalassemia patients. We have to deal with some new comorbidities which are, let's say, age-related, present also in the general population, but of course in thalassemia may be more present or in earlier stage compared to the general population. And moreover, of course, we have to deal also in adult thalassemia patients with some social and economical aspects which are part of a multidisciplinary approach. So increasing age, increasing the life span, what we need to look for? We need to look for a better quality of life, of course. We need to cure the disorders and the complications and the comorbidities. So let's start spending just few words in terms of quality of life. We know that beta thalassemia patients, these are data presented already published. We know that beta thalassemia patients, and we are of course talking mainly on transfusion dependent patients, had lower scores than general population. And comparing those with transfusion-dependent thalassemia with those with non-transfusion-dependent thalassemia, the so-called thalassemia intermedia, actually is quite important to note that the thalassemia intermedia had lower scores than patient transfused, because of course they complain more of the chronic anemia, which is corrected by transfusion in TDT patients. And looking at the follow-up of quality of life in these two cohorts of patients, we look at an impaired quality of life in thalassemia intermedia compared to those with transfusion-dependent thalassemia. And this is an important point to take into account because in some way we believe that thalassemia intermedia are lucky patients because are not transfusion dependent. However, these days we have to change a bit our mind because this cohort of thalassemia intermedia patients getting older and older, they complain a lot of clinical consequences and may be necessary to reconsider a transfusion scheme. Let's move to the age-related complication in thalassemia. Heart failure, although improved and significantly reduced thanks to the iron chelation, and particularly thanks to the oral iron chelation and to the availability of T2 star to measure iron load in the heart, as I already mentioned, we notice that thalassemia patients over the age of 40 have an increase of arrhythmias. And these, let's say, complications require a specific attention. We did recently a retrospective study in Italy from 8 Italian centers. The data have been just submitted to the American Journal of Hematology. And the aim of the study was to establish the prevalence of atrial fibrillation in almost 1,400 thalassemia patients. And without going into details, you can notice that the prevalence of atrial fibrillation in terms of percentage is increasing progressively according to decade of age. In patients aged over 50, the prevalence goes up to 22%, over 60 is 31%. And let's say, looking at males and females, it appears that males have a higher prevalence compared to females. And these are the symptoms at the first episode: palpitation, fatigue, dyspnea, poor tolerance to effort, and so on. Some of these may be underestimated, at least at the beginning, and then the consequences are quite important. So I think that these, although preliminary data, but suggest that arrhythmias and atrial fibrillation are important complication in adult thalassemia patient and deserved to be treated. Moving to another age-related complication, I want to recall your attention on cancer. Of course, it's difficult to estimate the real prevalence of cancer because we need to know the prevalence in the general population according also to the nation distribution. And for this reason, I would like to use some case presentation which occur in our experience. This is a 42-year-old man with transfusion-dependent thalassemia who presented with right upper quadrant pain. And the CT scan showed an extramedullary hematopoiesis masses. The liver function tests were normal, serum ferrit 11 and liver iron concentration were elevated, hepatitis B and C were negative. So since wasn't really convincing, a liver biopsy was performed and a liver cancer was diagnosed. This is another case of a 62-year-old splenectomized lady with thalassemia intermedia. And she presented with a left frontal mass of 3 weeks duration, and that was associated with a severe head age. The CT of the brain showed a left frontal mass eroding the bone. A fine needle aspirate taken from this lesion and the bone marrow aspirate reveal a beta cell lymphoma. And the patient was diagnosed as non-Hodgkin lymphoma in thalassemia intermedia, as you can see. So we have to keep in mind that thalassemia patients may have cancer. Sometimes we are keen to consider some masses or lesions as ineffective erythropoiesis, which is the case actually in many cases, but in some we have to consider the possibility of a malignancy. So there are no much data on that. Looking back to the literature, I found this paper, which is back to 2009 from Iran, where in a multi-center study in Iran, in 4 centers, they detected 11 cases among 4,600 patients. 8 of them were thalassemia major, 5 with lymphoma, 5 with leukemia, and only one had a non-hematological malignancy. 3 out of 11 were thalassemia intermedia, 2 of which had leukemia and 1 non-hematological malignancy. These is a, let's say, already dated paper. Data probably change. Paper from Taiwan in 2014, again in a non-longitudinal nationwide course study investigating the risk of cancer. They found the overall incidence of cancer in 1.5 times higher in thalassemia cohort than in a comparison cohort. And once again, they stress that thalassemia patients had a higher risk mainly for hematological malignancy and abdominal cancer. And restricting to transfusion-dependent thalassemia patients, they had 9.3-fold risk for developing hematological malignancy and 9.1 for non-hematological malignancy. This is a very recent paper in Italian cohort of patients showing the distribution of tumors in our population that was published in Cancer in 2023 and is the results of a collaborative study from the Italian Society for Thalassemia and Hemoglobinopathies. And you can see that liver cancer, thyroid cancer, and kidney cancer are the most common either in male or females in panel A. And if you look in panel B, considering that this evaluation was including any type of hemoglobinopathies, including also hemoglobin H and sickle cell disease, you can appreciate that the high number was detected in the red bar, which represent the transfusion-dependent thalassemia patients. And what is even more interesting from this data is that the incidence of new cases of cancer from 1984 to 2021 is significantly increasing, and you can see that from 2018 and 2021, the incidence, which means new cases for 1,000 patients per year, is significantly increasing, with a particular attention to be focused on hepatocellular carcinoma. So this, again, from this paper, there are some consideration. Actually, while the increased prevalence of solid cancer, mainly including hepatocellular carcinoma, take into account two risk factors as hepatitis C and iron overload, has been already noticed, there is a point to focus on, which is the occurrence, as I mentioned in the previous slide, the occurrence of hematologic malignancy, lymphoma, or any other type of leukemia. lymphomas, a role should be played by viral infection, for example, but maybe also at the level of bone marrow in overstimulation due to ineffective erythropoiesis, JAK2 mutation of chronic hypoxia may contribute to the development of hematological malignancy, has been summarized in these slides showing the possible mechanism of hematologic malignancy in thalassemia, including, as I said, the viral infection, but we cannot forget the iron overload and for those treated with hydroxyurea also to the potential, let's say, toxicity of hydroxyurea. So keeping in mind that cancers, any type of cancer, hematological or solid, in thalassemia patients may increase over the age, and particularly we notice the cases I mentioned over the age of 40, we need some surveillance in order to detect as early as possible the cancer, and particularly for hepatocellular carcinoma, which remain one of the most common in severely iron-loaded patients and patients with untreated hepatitis C. We need to keep in our monitoring schedule the ultrasonography at least once a year, and in transfusion-dependent patients, and maybe even more frequently in those who are not chelated. Some are not chelated among the thalassemia intermedia and are not treated for hepatitis C or B. And also we have to keep in mind that several of our patients are treated for hypogonadism, and in such case the hormonal therapy may also increase the risk of cancer. So we have to monitor carefully those patients. And of course, no doubt that having available the new antiviral agents, all the patients with hepatitis C should be considered for treatment. And of course, we have to be very careful in, let's say, screening the infectious disease agent in our blood transfusion in order to avoid potential infection due to blood transfusion, and of course iron chelation. So we mentioned so far arrhythmia and cancer. What about pulmonary hypertension? That is also a worrying complication in age-related, among the age-related complications. And once again, I want to show you a case. A 46-year-old splenectomized lady with thalassemia intermedia presented with progressive dyspnea of 2 weeks duration. She had 10 grams of hemoglobin, 850 platelets, 1,200 ferritin, and increased liver iron concentration. Actually, she had she performed a echocardiography, and she had a peak tricuspid valve regurgitant jet velocity increase 3.5, where the normal level are less than 2.5 milliseconds. And the right heart cardiac catheterization reveal a mean pulmonary arterial pressure of 45. So these patients was diagnosed having pulmonary hypertension. Why pulmonary hypertension in beta thalassemia? In beta thalassemia, PI is characterized by precapillary pulmonary hypertension in the absence of left-sided heart disease, lung disease, or chronic thromboembolism. The exact mechanism remains unknown because I prefer to say that is a multifactorial consequence. And in newer classification of PI, the PI in thalassemia belong to group 5 associated with chronic hemolytic anemia with unclear multifactorial mechanism. And the suggested mechanism include the hypercoagulability with thrombosis suggested to play a major role because we know clearly that these patients are at higher risk of thrombosis, particularly those splenectomized. Hemolysis and anemia also play a role in the nitric oxide pathway, and that has an impact on pulmonary function. Overexpression of endothelin inducing vasoconstriction. So there are some different components to develop pulmonary hypertension, which may play a role all together, or one may prevail on the other. And these are data from Optimal Care. Optimal Care, which is already dated as a publication back to 2010, but it was very informative, showing us that pulmonary hypertension, especially in non-transfused patients, has quite high prevalence in splenectomized patients, patients who had previous history of thromboembolic events, who had a high number of peripheral nucleated red cells, who were naivety for transfusion, for iron chelation, and for hydroxyurea. And in this paper, you can see that there is an increase of pulmonary hypertension. The study were conducted in thalassemia intermedia because it was more, let's say, a more useful population to conduct this study compared to the transfused one. You see that the increased PI in these patients was related also to the liver iron concentration, advancing age, splenectomy. So I should say that this bring us to consider that transfusing patients, we may prevent the hypercoagulability states. We may, of course, improve the anemia. We may improve the hemolysis, and in such approach, we may reduce the risk of pulmonary hypertension. And this algorithm, which was published but is present also in the recently published and updated TIF guideline, showed the approach for diagnosis pulmonary hypertension in thalassemia patients and what to do to treat them. So this, just to conclude the pulmonary hypertension, keep in mind that whenever patients complain, fatigue, dyspnea, the, let's say, heart and pulmonary situation should be evaluated. One more age-related complication in thalassemia is renal disease. The kidney was quite neglected, I should say, in thalassemia for many, many years. And once again, I show you a case presentation. This is a 53-year-old splenectomized man with thalassemia intermedia presented to the clinic for significant proteinuria. He had 10 grams of hemoglobin, 450 platelets, quite a large number of nucleated red cells, high serum ferritin, high liver iron concentration, and 140 ml for glomerular. He has a glomerular hyperfiltration. And sorry, the second one is a 45-year-old man with transfusion-dependent thalassemia presented to the clinic with recent onset of lower extremity edema. He had 10 grams of hemoglobin, high serum ferritin, a BUN-63, creatinine 2.7, a glomerular filtration of 25. He has high phosphorus, high uric acid, serum albumin 4.5, and urine beta 2 micro 1.1, urine ratio CACR 0.30, and proteinuria. So in both cases, patients developed liver failure, and at the end, they were put on hemodialysis. You can see one was thalassemia intermedia, but the other one was transfusion dependent. So what are the mechanisms or potential mechanism of renal disease in beta thalassemia? Well, we have again several different mechanisms, several different factors. First of all, anemia and hypoxia. These may cause reduce vascular resistance, increase renal plasma flow, increase GFR. And this may imply endothelial and epithelial damage and so on. But we have also the iron overload, which was never really estimated to impact significantly on renal filtration, but actually iron overload may cause tubular cell damage, epithelial mesenchymal transdifferentiation, tubulointerstitial injury, at the end of the day, a reduction of GFR. And then on the other side, could iron chelation also play a role? We have iron overload, but we may have also an impact on iron chelation. And for this regard, the particular attention was paid when deferasirox was introduced as oral iron chelator. So we may have different components. This is a 10-year follow-up of renal function in adult EDT patients, where a slow but progressive decline in renal function was observed. Of course, we have to keep in mind that with the age, even in the general population, there is a slow decline in GFR. But actually, we notice, the author actually noticed that in those patients who had a significant decline more than the general population and more than the general TDT population, so those among TDT population who had a significant decline had a progressive renal dysfunction. And here actually, why it doesn't go? Here actually, again, we need to consider the causes I mentioned before, and according to that, try to correct the potential causes. So we have, as I mentioned, chronic anemia, which should be corrected by transfusion. We had iron overload, that should be corrected by iron chelation, but of course, we have to monitor carefully the iron chelation in order to avoid over iron chelation. And these are some, this is a paper, an old paper published back to 2012, showing some markers of glomerular and tubular dysfunction in thalassemia patients, as you can see, including proteinuria, hematuria, and so on. And this is more recent, and it shows that in thalassemia intermedia, the renal dysfunction is again probably more increased, more evident than in transfusion-dependent patients, and correlate with the liver iron concentration and the number of nucleated red cells. This is a long-term follow-up with, once again, in thalassemia intermedia, is in a long-term follow-up of 127 patients. 6 develop an end-stage renal function, as it is monitored by liver biopsy also, and the causes were documented in a different way. So with that, I'm going to stop here, thanking to my colleagues and my fellow in Milan, and I'm ready to take any question. Thank you.
Thank you, Dr. Capellini, for that wonderful exposition of problem of thalassemia who have crossed the age of 30, have become adults. So we have our colleagues here who will like to ask you some question, share their experience, and I also invite all the audience to put their questions in the chat box. Before we go to our colleagues, can I ask one question? Though you have not discussed today, you had in your list the thalassemia bone disease. So one question is about the use of bisphosphonates. Do you recommend it on regular basis, especially the patients where DEXA scan shows that they have developed osteopenia, osteoporosis?
Yes, I didn't actually discuss it because it's a problem which
Discussion चल रही है,
starts even
जाओ।
in adolescence. So it's a general problem for thalassemia patients increasing in age, and my answer is yes. I mean, we are using biphosphonate in the majority of patients, and of course, we evaluate the general condition before starting the treatment, but the majority of patients are on biphosphonate. And of course, we recommend also physical activity, good nutrition, and let's say the lifestyle to be favorable for bone disease.
Thank you. Dr. Babita, your question.
Good morning, sir. Good morning, everybody. Thank you very much, Dr. Capellini, for the wonderful presentation. What an excellent slides. I think you have covered everything. I don't have a query, but I just can't resist myself commenting. I have a comment that those were the excellent slides, recent publications, and especially that slide for the renal mechanisms in the thalassemia. Basics you have touched, you have just discussed everything. Thank you very much, ma'am. We are blessed to have your talk, sir. Ma'am,
Thank you.
Thank you very much.
I suggest to look at the recent publication of the new edition of thalassemia in thalassemia guideline, where all these aspects are focused and explain with a figure as I mentioned in my presentation.
Right, ma'am. Thank you very much, ma'am. We are really blessed to have your talk.
Thank you.
Thank you.
And before we go to Dr. Rajat for his question, those patients who are on deferresirox, and if the urine starts showing proteinuria, or if their eGFR is getting affected, there will be absolute contraindication to continue deferresirox?
No, actually, no. It depends on the level of increase creatinine and impact on GFR. We published data on 10 years follow-up of patients on deferresirox, and we didn't see any, although there were fluctuation on these parameters you mentioned, we didn't see any patients reaching the stage of renal failure. Nevertheless, if you see not a single flare, but a trend in alteration of these parameters, my suggestion is to stop deferresirox for a while, and if the parameters goes back to the original one, the baseline one, you can re-challenge the patients on deferresirox, maybe starting with lower doses and then to increase progressively. If this is not possible because of persistent compromise renal function, in such case you can avoid deferresirox and use deferoxamine. I have to say that looking at all the three available iron chelator, deferripron, deferresirox, and deferoxamine, all three had some renal dysfunction. We didn't look in the past to DFO or deferripron effect. We start to look with deferaz. But all three had some renal effect. So we have to select according to the renal renal dysfunction progression.
Thank you so much. Rajat, your question.
Yeah, Dr. Capellini does a fantastic talk. So I'm a pediatric hematologist who advises strongly for transplantation.
Yeah.
And my question to you is, now I see even when the patients I counsel about transplantation, there is a question about long-term side effects. So if I have to talk to them about lung problem, heart problem, kidney problem, secondary cancer, which in your mind is more of an evil Is it transplant-related long-term toxicity or non-transplanting and then getting into all this problem? Do you have any word of wisdom on it? Which is the more of a problem, you think? The long-term effects.
If I understood correctly the question, you are asking which of these long-term complications may impact on bone marrow transplantation outcome?
No, slightly different. So when I counsel patients about transplant and they ask about the long-term side effects, I will tell them, okay, you have these side effects. But then I never talk about if they just carry on transfusion, about increased risk of kidney function problem, liver function, which you think is a greater evil, and how do I counsel them?
Okay, this is a very good question. First of all, is very much dependent on age. So if you are consulting a family for a child or an adolescent, of course you have to discuss the long-term side effect of bone marrow transplantation, but you can also mention them the risk of still heart complication related to iron overload and so on. So I think that the iron-related complication should be the first point to mention to the patients. Secondly, of course, you can say, okay, with the standard of care, you may survive over 50, but you have to keep in mind, of course, the risk of some complication related to splenectomy, because some of these patients may go, hopefully not, but some may go under splenectomy or are already splenectomized, and I will focus on thrombotic risk, which is quite important, and it may have as a consequences pulmonary hypertension and so on. So these are the main point I will stress if you are consulting a child or an adolescent. If you are consulting an adult patient, although, as you know, the age for a successful bone marrow transplantation is below the age of 14. But if you are consulting an adult, what I will mention is his or her clinical complication already present, because that can impact on the bone marrow outcome. So, you know, it has to be adapted case by case.
Thank you.
Thank you, Dr. Rajat. Before Dr. Mehak, I will have one case to be discussed with you. This is a 22-year-old anti-DT whom I saw for cord compression due to extramedullary mass at about D4, D5. He wasn't very keen on getting on transfusions. Finally, we had to give a low dose of radiation to get rid of this mass. He's still not very keen on transfusion regimen, and he desires to go on luspatercept. Now, one of the complications of luspatercept is extramedullary masses increase or develop. So would you allow me to give him luspatercept, or he must accept transfusion regimen?
Okay, I don't think luspatercept should be considered for treating bone marrow extramedullary masses. At least in the beginning, it can cause expansion. Maybe then it stabilizes the masses, but is not my choice. What I suggest in such patients is the use of hydroxyurea. We had very, very positive experience giving hydroxyurea possibly associated to transfusion. But if patients refuse transfusion, start in any case with hydroxyurea. And I saw really very, very positive results. Masses, the masses doesn't really reduce in volume, but it reduce in activity, so are non-functional masses, and the compression is definitely less. I had a patient with paraplegia, and since I started hydroxyurea, progressively they improve. So just to conclude, no luspatercept, hydroxyurea, and possibly some transfusion.
Thank you so much. Dr. Mehak, your question.
Good afternoon, ma'am and sir. Thank you, ma'am, for an insightful and forward-looking talk. I would like to ask about reproductive health in such patients. So what fertility preservation options should be discussed with thalassemia patients approaching their 30s, considering the impact of iron overload and chelation therapies on reproductive health?
So we consider preservation just in patients who are undergoing bone marrow transplantation. We don't consider it in the other patients, the majority of whom age over 30 are hypogonadic and they require stimulation to become pregnant. In the youngest generation, I mean those who are less than 20, who are actually fertile, we do preservation only for those who are undergoing bone marrow transplantation or for the future undergoing gene therapy or something like that. And I cannot tell you the procedure exactly because I don't follow them. We send them to our colleague who have a unit dedicated to that.
Thank you. Thank you.
Thank you. Dr. Capellini, have you ever seen azoospermia reversing in an adult male with iron overload, transfusions, and if it's totally azoospermic, does it reverse with proper chelation, etc.?
I should say no. Most of the endocrine problem, including hypogonadism, are not really reversible, even with intensive chelation. Although, in my mind, there was a paper years ago by Pharmakis, if I'm correct, who published some data on endocrine problem reversibility with intensive chelation, including intensive means deferipron and deferoxamine. I never saw any reversibility of azoospermia.
Right. Thank you. Dr. Shruti, your question.
Good morning, Dr. Capellini. It's always a pleasure to listen to you, and thank you for coming up every now and then to update us about thalassemia management. Dr. Capellini, my question is that with the government setup, there are thalassemia centers or transfusion centers which are coming up in smaller cities now. And you have shown data very nicely that there is a lot of difference in the outcome when a patient is being managed in a specialized versus a non-specialized center. But with the healthcare changes in India, the patients are now getting transfusion in smaller cities, and we are not seeing them in any of the specialized centers. So what do you think is the right mix here? we can't have them traveling longer distances for every transfusion. So how frequently, and what should be, your recommendation as probably a TIF, advisor as well? How frequently should the government stress upon reference to a, tertiary center that
Yeah,
child or a patient?
Yeah. This is a very good question. I didn't really focus too much on that, but in my slide of Italian outcome, there was a small window showing that if patients are followed in expert center, the outcome is better. And this is not really surprising. And the situation you mentioned is getting to be common and common everywhere because traveling or even the structure of the health system is requiring to be treated or followed everywhere. What I suggest in such case is I know that India is so big, and it's quite difficult, but it should be done area by area, is to create hub and spoke center. So is to try to create a network and networking between the expert, let's say, center and those center who are just receiving patients for transfusion and iron chelation. So this can be done even online, networking, trying to update people in smaller centers in order at least to follow the standard for the standard of care. And then according to the age and severity of patients, you may, as a expert center, review the patients and visit the patients once a year or sometimes even once every other years. Of course, is depend very much on how you can interact with this small center taking care of that specific patients. This is the only way I see. And the other point is also to have educational meetings. So in these networking virtual activities, you may try to, let's use the term, educate your colleague in smaller center. What I'm not, let's say, pushing or in favor to is to ask every center, including the small one, to have all the facilities. For example, MRI should be present in one center for an area, and patients can be centralized, or some other investigating parameters should be performed in a centralized center. But that implies an education and networking among centers.
Thank you, Dr. Kaplan.
Thank you, Dr. Shruti. One question from the adult thalassemia major who is transfusion dependent is, he's getting recurrent ankle ulcers. They heal, but they recur. He's not on hydroxyurea. Any permanent solution?
Sorry, what is getting?
Recurrent leg ulcers.
Okay. Leg ulcers are really difficult to be treated. In my personal experience, I don't see leg ulcer anymore in transfusion-dependent patients. I have very few, I should say, couple or three or 3 patients with thalassemia intermedia with leg ulcers, and that's very difficult to treat. We implement increase iron transfusion regimen. We may use hydroxyurea, but in some cases has been reported that the hydroxyurea is even worsening the leg ulcers. So we start with, but if you don't see any results in 1 month, we stop it and we look for alternative. We did experimentally the use of platelets concentration in one case, which is successful at the beginning, but then it was recurrent. And then we didn't try, but there are some reports on hyperbaric treatment. So it is really very difficult. I personally suggest to increase the level of hemoglobin with transfusion and to keep a very careful, let's say, local treatment of the ulcer, keeping, is a kind of local treatment, local medication, which should be done by expert people, cleaning the leg, putting antibiotics, and so on. Unfortunately, is a difficult complication to manage.
There is a published case of loose patricept helping.
Yeah, that is very exciting at the beginning because in the phase 2 study, we had 2 cases. They were actually Italian cases who showed a significant improvement of leg ulcer at the beginning, after a few injections of luspatercept, and that was exciting. In phase 3, we had no inclusion, no patient with leg ulcer were included. So in the clinical trial, we didn't have more data. Now, in real life, where a physician can treat also patients with leg ulcer, let's see, we may have some results, but so far we don't have data yet. So I think that in a couple of years, with more patient treated in real life, we may have some with the leg ulcer and see what happens. If you ask me, may I treat the patients with a leg ulcer with luspatercept? The answer is yes. If you can use in real life luspatercept, why not? I cannot guarantee the response, but why not?
Sure. Similarly, in anti-DT, will you ever recommend splenectomy for the healing of recurrent leg ulcer?
If I remember correctly, in the optimal care study, splenectomy was not really a factor responsible for leg ulcer.